Okay. These are my disclosures. I have no relevant stock monitor or oil health. So, melanoma, unfortunately, has been increasing in incidence over the last many years, we've seen it plateau starting in the 90s, I think in large part due to the success of earlier detection and surgery. That the medical oncologist now is starting to make an impact, and I'm really thrilled to be a part of that. Another look, this is more contemporary data, just looking at the new case volumes that we're seeing in melanoma, and they unfortunately do continue to rise. But the death due to disease remains flat, and again, I think this reflects some advances in therapy. So I think to understand adjuvant therapy, it's important to go back and just give you a quick primer on melanoma. First of all, where melanoma cells come from, and then second, why are they so hard to kill? And you heard some of this from Drs. Bowen and Borrell a little earlier, but one thing that I don't think any of the speakers have pointed out yet is that during our development, melanoma cells go on a great migration. So as we're kind of going from embryo to adult organism, there are many events that kind of arise from folding events that give rise to future organs. Well, our melanocytes actually travel from this structure here through connective tissue and then set up shop in the skin. And it's that very feature of the ability to transit other tissues and colonize these sites that makes a melanocyte somewhat deadly. Because as they go back to cancer, they kind of forget what they're supposed to do, and they can learn all those evasion strategies all over again. As you heard about before, their major job in life is to be a free radical sponge, i.e. they're basically always trying to protect the cells adjacent to them from UV light. And they have a high DNA repair capacity, meaning that they can actually repair damage, particularly damage caused by our traditional chemo, which is why so many of the therapies that we have used in the past have not worked. They also have pro-survival factors, which allow them to persist a long time. And there are hours of molecular biology that we could talk about on that subject. You heard from Dr. Investigum the importance of mutations with melanoma. And as these mutations go up, you can see melanoma is one of the most mutated cancers of all. So does the ability of our immune system to recognize those changes. So in a way, this is a sword that cuts two ways. So to the topic that I want to share with you today, micrometastatic disease we've known about in melanoma for some time. When our patients present, it's usually a spot on the skin or maybe something in the lymph node, and what we can actually see is only the tip of that iceberg. What's actually present within many of those patients is cancer that has already spread, and that's what we have to deal with. And we calculate that there may be as many as, or rather more than 1 million tumor cells remaining in a patient even after a good surgery. How do we come up with that number? Well, it's actually looking at the doubling time. How long does it take to grow a tumor of appreciable size in a patient who sadly relapses from melanoma? And that's how we figure this all out. Now, not every patient relapses, but we know at the time of surgery that some have as much as a 50% risk of a relapse, and those are the patients who come to see me for adjuvant therapy. The idea of this has been around a long time, and it really started back in 1984 with interferon. A lot of the basic science that went into interferon development occurred during the 80s. There may be a patient or two in the audience here that actually was treated with interferon because for a long time, this was the only thing that we had that could prevent those relapses. Well, things began changing. We had pegylated interferon approved just after 2009. And then ultimately, ipilimumab, nivolumab, dabrafenib, trametinib, and pembrolizumab have all been approved for adjuvant therapy. So there's a lot of really great new stuff in our clinic. And I'm glad to say I don't have to put my patients through interferon any longer. That is a tough treatment. So, what are the impacts of some of these treatments? And I'm going to go in a brief, more contemporaneous history of adjuvant therapy. One of the more recently reported trials was this one appearing in the New England Journal in 2016 that compared placebo to high-dose ipilimumab. And this is actually given at a higher dose than we typically give ipilimumab now in our clinics at 10 per kilo. And that showed an improvement in relapse-free survival by a hazard ratio of 0.76. Now, this sometimes gets to math, and often my eye really is over with math. So I'm going to try and distill this into sort of a more simple concept. When we talk to patients about how we're going to prevent a relapse, we have to think about the statistics and how likely is that therapy going to improve their ability to remain relapse-free over time. By doing that, we calculate something called a hazard ratio, and in this case, hazard ratio of 0.76 is going to have a reduction of about 25% of that patient's risk of relapse. And I think you can visually see that. If I just took a time point here at 5 years, and I looked at this as my total volume of risk, you can kind of split and see that about a quarter of patients are relapsing as a result of that treatment. Fortunately, we are getting better. So some of the more contemporary studies, one looking at targeted therapy versus placebo, we're now looking at hazard ratios of 0.47, meaning that we're cutting that total risk in half of a relapse by giving that therapy for over a year. And we've also seen immune therapy, pembrolizumab, which you heard a lot about earlier, cutting that same risk by close to a half in comparison to placebo. So we've come a long way, something happened here. Sorry. Citrix is trying to talk to the computer while I'm talking to you. Okay, bye, Citrix. What's more important than relapse is actually how long people will live. And that is the data that we're hoping that we'll see mature over a long period of time. These are overall survival curves of patients beginning the course of their treatment. So for a stage 3 patient, and someone who had a positive lymph node, with treatment with ipilimumab, we would have expected them to have a 65% chance of being alive at 5 years versus placebo at 54. But look at these curves. Now with the Grossmann and trametinib, we're seeing close to 90% of those patients having long-term life expectancy. So these drugs are really making a difference. We don't yet know the data for mature life expectancies on the Nivo and Pembro trials, and we're hopeful that we see those updated soon. So another question you might ask is, which PD-1 is better? And I've shown you 2 trials, one with nivolumab, which was compared to Ipi, and showing better, and a second with pembrolizumab compared to placebo, also showing better. When we do cross-trial comparison in cancer, we really want to have things that are internally compared within trials. It allows us to control variables like age and risk and comorbidity. When we look at cross-trials, it's a bit like trying to compare apples and oranges, but from the data that we've seen, this one had a higher risk population than this trial, and so you might expect the survivorship on Nivo to be a little bit lower at 2 years than what we saw with Pembro. So really, these are equivalent. I kind of consider them Pepsi, Nivo or Pembro. It doesn't matter so much. What is different about the two is the frequency of their administration. Nivo being given every 4 weeks, pembrolizumab being given every 3. And so patients that are coming to my clinic are often just deciding, based on their calendar, what time will get better schedule to do. Ongoing research is helpful to answer more questions about this, and this is a study that I worked on as a part of Southwest Oncology group, which was mentioned before. It was a trial that compared pembrolizumab, which at the time we designed it to have this number, the Merck drug, and it was compared to high-dose interferon or ipilimumab. The patients actually had a choice on this trial because they didn't know yet which was better, interferon or ipilimumab. I share this with you just to give you some background of how we think about clinical research. All the patients who enter have to meet eligibility criteria. So if you ever meet with your physician to talk about participation, they're going to be going through something like this to make sure that you check all the boxes for inclusion. Secondly, with this trial, we wanted and shared most about whether or not this treatment would extend life. And when you design studies and power them, you want to make sure that you have enough patients to prove this at the end of the day. So this trial is powered to do that. We're also measuring many other things with the trial, which included how well we prevent distant metastases, what's the toxicity of these drugs, And then I think very importantly, something that we haven't touched a lot on, but we're measuring patient-reported outcomes. So what is it that you all can tell us as you're going through these therapies on forums and with your experience about what you're feeling on these therapies? And those patient-reported outcomes are coming from a lot of the research that I just described, and I really can't wait to see the data. This was an international trial. So this study was run across 289 sites, including international in Ireland and Canada. Utah was a major contributor to this. And in fact, if you added up all the patients in Utah that contributed their experience to the trial, we were actually third around the world in our contribution to that research. Second only to MD Anderson and Moffitt Cancer Center in Florida. So the goal of the study, we hope to have data to present sometime in 2020. It can take a while to mature. We have a number of research projects that are going on with the tissue, some of these led by Dr. Grossmann, others in the audience are participating. Dr. Coleman, who's been back there quiet, is going to be looking at some data from the trial as well. And we learned a ton from the contributions from the people in this room, and the work is ongoing. So here's a summary of where all of the different adjuvant options fit. And these hazard ratios, now that you know what a hazard ratio is, you can kind of do the math in your head if you like. But it's important when you look at these to know which trial was compared to a placebo and which was compared to an active drug. And I think you can appreciate the slight differences here when you're looking at those things. We have learned that Pbjectives is better than high-dose interferon. That result was reported just this last summer in June. We expect many other data points, including combinations of nivolumab and ipilimumab, as well as the 1801 trial, which you've heard mentioned a couple of times. This one I'll just highlight as being so important to understand whether or not we can give a treatment before a surgery and whether that would be better than giving a treatment after the surgery. So which treatment is right for you? And I think that boils down to any patient who has a high-risk melanoma, something that is in the lymph node. I really think there's equipoise between pembrolizumab, nivolumab, or dabrafenib and trametinib, which are our oral drugs. If you have a large or palpable lymph node at the time of your first visit with your doctor, you really should consider a neoadjuvant trial such as S1801. And then I think a frontier that we're just beginning to explore are what to do about those patients that are high risk stage 2, meaning those that have a thick tumor but no positive lymph node. And there are 2 ongoing studies which are placebo-controlled comparing pembro and nivo in that category. Finally, I think analysis prevention is worth a pound of cure. I like showing this slide because these are my great-grandparents. And I like to think they were ahead of the time. They are standing on the shores of Lake Michigan at the Indiana Sand Dunes, if anyone's familiar. And my great-grandfather is wearing a school do-rag and a shirt here. He's covering his trunk, which is actually where most men get their melanomas. It's usually on the back or axial portion of their skin. And my grandmother's ahead of her time too because she's wearing stockings, and this is where women get their melanomas. My son's trying to take this to the next level, so this is combination prevention. He's got a hat, the shades, the sunscreen, the life jacket, and the French bulldog, all kind of protecting him. And I thank you for your attention.